Hello, my name is Aran, and today I will be talking about healthcare utilization trends associated with suicide death among people living with HIV in British Columbia, Canada, between 1998 and 2012. Before I begin, I would like to thank CAR for the opportunity to present and to state that I have no conflicts of interest to disclose. I would also like to thank and acknowledge everyone who contributed to this project and my co-authors listed here. I'd like to begin with a land acknowledgement and recognize that I am very privileged to be doing this work on the unceded Coast Salish territories, the traditional lands of the Musqueam, Squamish, and Tsleil-Waututh peoples. So, studies have shown that rates of suicide in the province of British Columbia are decreasing over time, though the rates of suicide for people living with HIV are substantially higher when compared to the HIV-negative population. To explore these rates, we looked to healthcare utilization trends to help identify underlying healthcare interaction patterns for those at risk of suicide. Our objectives were to identify levels of engagement within the healthcare system for people living with HIV up to 90 days prior to death between the years of 1998 and 2012 in BC. The exposure of interest is the rates and types of healthcare code billings, and the outcome of interest is death by suicide. We hypothesized that people living with HIV who died by suicide interact with the healthcare systems less than people living with HIV who died by all other causes. A point of clarification for why we are using code counts instead of number of visits is because it is very much possible to have multiple codes billed for a single visit, especially if it is a hospitalization event. Though this is not very common, we wanted to be able to capture the amount of codes that were presented in this way. The 5 code categories that we used are listed here. Any healthcare codes indicates one or more healthcare codes billed within the 90-day time frame. Total healthcare codes looks at the total number of healthcare codes billed within the 90 days. Mental healthcare codes are health codes related to mental health visits. Self-harm related codes are codes related to injury, poisoning, and other self-harm. And the all other healthcare codes category is a summation of all of the code categories except for self-harm. We use codes available in the DAD and MSP, so Discharge Abstract Database and Medical Services Plan. I will touch briefly on those 2 data sources on the next slide. This table here is an example of how code categories were defined for this analysis, as well as their respective ICD-9 and ICD-10 CA codes. The study that was used was the Comparative Outcomes and Service Utilization Trends, or COAST study. COAST is a population-based longitudinal cohort study that uses linked datasets from the BC Centre for Excellence in HIV and AIDS and Population Data BC. Population Data BC is the province's repository of administrative health data. So the following data sets and their sources were used for this analysis. I want to draw your attention to the Discharge Abstract Database, which includes hospital discharge data, where some of the codes used for this analysis came from, and the Medical Services Plan dataset that has all the physician-billed ICD-9, ICD-10 CA codes used. Their sources and their references are listed here. For our participants, we included everyone in the drug treatment program cohort within COAST who had a confirmed HIV diagnosis in the dataset. We excluded those who did not have a death event prior to the end of the study or who had a pending death code. We also included those who did not have at least 90 days of follow-up. You can see here on the right that a total of 226 people were excluded for those reasons. In the final study cohort, we had a total of 71 deaths by suicide and 2,292 deaths of all other causes. Using the previously mentioned healthcare data codes within COAST, we performed bivariable and 5 separate multivariable logistic regression models to examine associations between healthcare utilization and the death by suicide outcome. In these analyses, we controlled for age at death, sex, health authority in the province of BC, neighborhood income quintile, which is a 5-level variable derived from forward sortation area using postal code information from the census, and it's essentially a proxy for socioeconomic status. And we used time period of death. It was stratified into a 3-level variable that was based on the advances in antiretroviral therapy changes since 1998. For the main exposures here, the total healthcare, self-harm, and all other death count categories were significantly different for those who died by suicide versus all other deaths. For the covariates, age at death, as shown on the table here and on the figures on the right-hand side, neighborhood income quintile and sex were significantly different. But as you can see, time period of death and health authority were not significantly different. 5 separate models were run for each of the main exposures. All analyses controlled for age at death, sex, health authority, neighborhood quintile, and time period of death. Adjusted models show that people living with HIV who died of suicide had a lower total number of healthcare codes billed, a lower number of healthcare codes other than mental health and self-harm billed. We found a higher number of healthcare codes related to self-harm billed, and mental health care codes were not significantly associated with suicide death. This slide is a summary of the results already discussed. I'd like to draw your attention to the first bullet point that states people living with HIV who died by suicide had significantly lower healthcare counts compared to people living with HIV who died of all other causes, which indicates a difference in healthcare access patterns for both groups. As you can see, the median number of codes billed in the 90 days prior to death for those who died by suicide was 4, whereas for those who died of all other causes was 13. There are potential limitations inherent to the use of administrative health data like COAST. These include possible code billing errors, a risk of information bias, and the potential for misclassification of exposure. So an example that pertains to this study, there could be a misclassified code billed during a hospitalization stay, for example. Also, we were limited in the number of potential confounders we were able to adjust for, but this is a limitation inherent to most all administrative data sets. Despite these, administrative health data is an invaluable tool for statistical analyses and a standard way of epidemiologically identifying potential associations between exposures and disease outcome patterns. Our study results suggest that people living with HIV who died by suicide engage with the healthcare system less when compared to those who died of all other causes, although we found no significant differences in mental health care code presentations. This analysis showed a clear indication for risk of self-harm, as the rates were higher for people living with HIV who died by suicide. This clearly highlights potential missed opportunities for suicide prevention at the healthcare system level. The future for this analysis will look specifically to expand this research question by adding a comparative control group of HIV-negative people in the COAST dataset, and to analyze more recent trends in the data and potentially focus on more socioeconomic factors and things such as comorbidities. I'd like to acknowledge all organizations and funders listed here for their support and to thank you for attending this presentation.